Good morning. My name is RichardShannon. I'm the Executive Vice President for Health Affairs at the University of Virginia, and I'm going to spend a few minutes sharing with you some of the early findings of our foray into becoming a high-performing organization through a process of a culture of continuous learning. Academic medical centers in many ways are the jewels in the crown of the U.S. healthcare system. They have been the bastions of learning, the fonts of new discovery and innovation, much of which you'll hear later today. They have the unique responsibility of training the next generation of providers. But I would submit academic medicine has been conspicuously absent in terms of its leadership in delivery system reform, even as we recognize the quest for higher quality at lower cost. And I will submit to you today a hypothesis that this is because academic medical centers themselves are not learning organizations. The current state of most academic medical centers is a wanton infatuation with reportable but inactionable data. What does 5.3 infections per 1,000 line days mean? What does a mortality ratio of 0.7 mean? The masking of clinical data in unintelligible metrics limits the ability of frontline workers to engage in improvement. We are awash in meaningless measures. 1,700 National Quality Forum measures allow 1,000 U.S. hospitals to claim they're in the top 100 performers. The most commonly employed discipline problem-solving effect in quality in American medical centers is the Hawthorne effect, repeated measurement. There is virtually no room for staff to engage in daily learning about how to improve work. And as a consequence, American healthcare workers are working harder and harder and achieving less and less. Now, nowhere is this perversion more evident than in public reporting. Here are 4 public reports that report out on American health system outcomes, designed to increase and motivate quality and transparency. But in a recent article published in Health Affairs, only 10% of 844 hospitals rated as high-performing by one of those organizations actually was thought to be high-performing by any of the other 3. So to the public, what does that say? It says Angie's List is a better place to go find what is quality healthcare than public reporting. Our own organization reports 484 individual measures to 12 different public reporting agencies. We have created a cottage industry of reporting, not a focus on improvement. We report mortality to 8 different organizations, and our mortality scores are 4 different numbers in 8 organizations. How can that be? This chaos in the frontline delivery system has the pejorative effect of diminishing the impact of much of the technology that you're going to hear. A great example of that is the relative quest for the kinds of outcomes we all expected from the electronic medical record that continue to be awash when they're imposed on chaotic delivery systems. Now, the context of this dilemma is couched in an argument that exists between the payers, which you just heard, and the provider community. And while there is an inextricable link, they are 2 distinct arms of this dilemma. The payers face a demographic problem, which is the baby boomers. 10,000 Americans become Medicare beneficiaries today, and 10,000 more tomorrow, and in fact 10,000 every day for the next 19 years. The bottom graph here illustrates the doubling of Medicare beneficiaries over the last 50 years since the inception of this important national social program, and the nearly 20-fold rise in the per capita expenditure on each Medicare beneficiary. This is the challenge for the payer community. On the right-hand side is the opportunity for the provider community, which is using Don Berwick's levers of waste that exist in the existing system and borrowing on the consistent projections that somewhere between 21 and 47% of what we do in healthcare today adds no value to a patient. I would submit to you the opportunity for the provider community is the elimination of waste embedded in harm, defects of care delivery, defects of care transitions, overtreatment, excess administrative costs, and fraud and abuse. So what does a high-performing learning organization look like? It's about mastery, not performance. It's about the idea that you can't be great unless you're really good at everything. So habitual excellence requires continuous improvement, and continuous improvement requires continuous learning. Continuous learning means an organization must have a critical thinking approach based on a common disciplined problem-solving capability that everybody in the organization communicates with. Now, as organizational leaders, and I am a leader of one, we continuously balk at the price of this type of improvement without ever stopping to calculate the embedded costs of doing things in average fashion. And an example of a high-performing organization is illustrated in this small image here, which is an Alcoa aluminum manufacturing plant in Alcoa, Tennessee. If you wonder how important Alcoa is to Alcoa, Tennessee, they named the town after it. They make hot molten metal at 2,000 degrees on 10-ton cranes going over 2 football field lengths manufacturing floors. This is one of America's best hospitals. And my question to you is, which is safer, to work at an Alcoa aluminum plant or a U.S. hospital? It is 27 times safer to work at Alcoa than to work in the very best U.S. hospitals. And the difference here is a leader, Paul O'Neill, who stated a proposition that the business model of Alcoa will be no worker gets hurt. And from that, increased the market capitalization of Alcoa 800-fold. A recognition that the workforce was the focus of innovation and technological transformation at Alcoa. It's really important to understand the characteristics of transformative leaders like that and to look across healthcare for where we might find them. This comes from Steve Spear's book on High Velocity Edge, and he describes very succinctly the characteristics of leaders of high-performing organizations. I commend them to your consideration as you think about the delivery systems in which we work. Above all else, leaders create clear and unambiguous expectations. They don't know the answer. They create systems that discover the answers. They themselves are amazing problem solvers and rose to the top of the organization because of their problem solving capability. How leaders are seen spending their time is a reflection of their values. As a leader, go back and look at today's Outlook schedule and ask yourself the question, does what I do today actually reflect the things that are meaningful to me? And then finally, leaders in high-performing organizations take away all the excuses why we can't. So to frame the idea of a learning organization in an academic medical center, we've embarked over the last 15 months on creating a continuous learning enterprise called Be Safe. This is the roadmap for the enterprise, and I'll just take it through at a very high level, and you can study it at your leisure. It begins with a shared purpose, which is an alignment of goals, the first of which is to become the safest place to receive care. It is built upon a core set of values that senior leaders are expected to practice every day. It is bounded by a disciplined problem-solving capability that in this case derives its origin from lean manufacturing thinking. It is predicated on a daily report of updated metrics and daily work assigned at each point of care toward a global implementation plan that is, in its first year, designed to increase frontline staff engagement. And you can't see this here, but the big blue bars are near doubling in frontline staff engagement in the belief that quality and safety matter in the organization, largely because leaders are seen practicing these values. We've trained 700 frontline workers, mostly nurses, in lean manufacturing thinking principles designed to see and solve problems in real time to root cause every day. And this is the lean tool that we use for real-time problem solving. This is an A3 for those of you familiar with the lean thinking. I'm actually agnostic as to the common language you use, but this is what we've adopted. The business case here to become the safest place for workers and patients. the metrics by which we measure our baseline of our progress toward the goal. Clear, silent observations by leaders and workers around the current condition, with root cause problem solving of defects defined in the course of care. A target condition generated toward the goal, and then a who, what, when, and why that is publicly visible across the organization so that there is accountability in every corner. And this is anchored by a critical component of the leadership team called the health chain, in which the unit-based clinical leadership teams empowered with problem-solving capabilities rely upon the C-suite to help them solve problems that they alone can't solve. And it is anchored by one goal: meeting a patient's need when they need it, on time, the first time, without defect error space. Now, in a 15-month period, we've been able to see very dramatic early changes by applying at the front of care these disciplined approaches. You can see here lots of fewer infections. Doing a simultaneous business case, this will result in a $2.6 million improvement to the operation. 109 fewer pediatric infections, resulting in a $2.4 million opportunity. 53 fewer sepsis deaths in the organization. You hear a little bit about some of the technology behind that. $1.83 million. 36 fewer falls, $82,000. 46 fewer pressure ulcers, $1.6 million. 95% reduction in frontline nursing staff stockouts. This has resulted in a $3.6 billion improvement in our supply chain and the realization across the organization of 64 hours of nursing time per month per unit, which aggregates to a $21 billion recouping of wasted nursing time. And then finally, 96 fewer worker injuries, which is above our most prices. Now, the final thing I want to leave you with is this kind of critical thinking not only can be applied at the front lines, but in the C-suite, where many capital commitments are made. So when I was at Penn before I came to UVA, the first meeting I went to was about building a parking garage, where they said, Dr. Shannon, we need to build a 6-story parking garage. It's going to cost $30 million. I want to show you the plan. And I said, why do you need a parking garage? They said, well, we just got here, but no patient can find a place to park. And I said, well, really? And they said, absolutely, there's no place to park for patients. I said, well, what about at 8 o'clock in the morning? There's only plenty of places to park. So what about at 5 o'clock in the afternoon? All kinds of parking places. So, well, what's the problem? I said, well, between 9 o'clock and 3 o'clock, there's no place to park. I said, how about at night? The garage is empty. What about weekends? Nobody's there. So I said, we're going to spend $30 million to solve a parking problem Monday through Thursday from 9 to 3. They said, that's absolutely right. You got it. But the real critical problem here wasn't parking. It was waiting. We held people captive between 9 o'clock and 3 o'clock, encumbered in a chaotic system. So the solution to this was to apply a value stream process to care delivery. And this is my heart failure clinic when we started. You called for an appointment. It took 14 days to get an appointment. Now, I had just arrived at Penn. I had no patients. When I asked the front desk staff, why did it take 14 days? They said, Dr. Shannon, no one will think you're good if they can see you right away. Took 57 minutes for this patient to drive into Philadelphia. I can't do much about that. 22 minutes to park, 31 minutes to register. This was a person that had been seen at Penn for 11 years. Every registration, what's your birth date? What's your social security number? Do they change? 23 minutes waiting in one of our palatial waiting rooms. We built an ambulatory center at Penn for $300 million. 40% of it was waiting rooms. 40% of the new space, waiting rooms. 18 minutes, the most efficient step was the nurse's assistant taking valid vital signs. 18 minutes waiting in one of those drafting gowns in a cold exam room. 17 minutes with me, the doctor. 14 minutes to check out. 97 minutes to get the checks, and 18 minutes to exit the garage. For a 17-minute value added, arguably, visit with the doctor, it took 4 hours and 5 minutes for the person to leave. And in fact, we made more money on parking than we did on the visit, right? This was a Ponzi scheme. When you go back and say, what does not add value, and eliminate the waits by redesigning the system, suddenly a patient spends 2 hours for the same value-added time, spends $8 in parking, and guess what? You have twice as many parking spots. And metrics that matter more include the ability to see more patients at the same time, to increase on-time performance for the doctor, to increase patient satisfaction, and to decrease the time to be seen. So really critical thinking using data-driven analytics becomes a powerful tool for us to do this. And then finally, I think academic medicine has to get out of this mindset. As the healthcare system takes on water, we will not survive sitting in the back thinking that this is somebody else's problem. Thank you.